My name is Craig Cole, and I'm from Michigan State University College of Human Medicine and Karmanos Cancer Institute.
I am Dr. Lalit Kumar. I am a medical oncologist. I was at the Colony Institute of Medical Sciences, New Delhi, in India.
And today we talked about our disparities in care of myeloma. And what that means is that myeloma, as we know, has tremendous strides in care. Incredible things have been talked about at this meeting. We've have new drugs, new opportunities to treat this disease and potentially cure this disease. However, one thing that we know is that the delivery of care isn't equal. It's not equal in the United States. It's not equal around the world. And some of those differences about who receives the newest treatments, who receives the best diagnosis, who receives the expert care is very different because there are populations in the United States and the world that don't have access to those drugs. And that was what we really highlighted today.
Yeah. The incidence of multiple myeloma is quite variable and varies from one part to another. For example, in Australia and New Zealand, incidence is very high, almost 5.6 per 100,000 people. Compared to this, North America has 5.2 and Western Europe has 4.6, while in Asia it's like 1.1 or 1.2. So there has been huge variation in the incidence of myeloma and around the world. So that was one of the initial point which we made, and subsequently we discussed like what are the other differences, like in the terms of clinical presentation, in terms of investigations. For example, many patients in Asia, for example, they present very linked. This could be due to many reasons. Could be the healthcare availability of healthcare in different centers, which may be, and there are only few centers which may have at the main teaching hospitals where the patients have to travel long distance to go there. So that could be one of the reasons that why people come very late to these places.
And one thing that we know and has been discussed is that the incidence of myeloma is higher in people of African descent. So African Americans, Black people, Black people around the world have a higher incidence of myeloma, almost double that of whites. Why that is, we don't know. It's not because of a lack of trying, but it's probably something that's hidden deep inside the genome between blacks and whites that have that higher incidence of myeloma. One thing that Dr. Kumar had mentioned is when you look at the number of people diagnosed with myeloma, it's actually lowest in Africa, which is counterintuitive of what you would think. That people of African descent have a higher incidence. Why would the diagnosis be so much lower? That's because of access. Because in those areas that are poorer, don't have access to the diagnostic modalities that we have, and therefore there are people that have this disease that don't know that they have it, and then of course they don't know that they have it, then they end up dying of the disease without treatment.
So, for example, like some of the new end investigations, like the imaging, the PET CT scan is not available at many centers in Asia, only limited to the major teaching hospitals or major big hospitals. Similarly, the investigation like fish, chromosomal analysis is not at every place. And like serum free light chain assay, again, it may not be available at many places. So, so this is one part of this, and what we suggested, how this can be bridged is that we can have a hub and spoke model, where the big major centers where these facilities are available, patients are referred to those places. This will bring down the cost, and that you can have a bigger data from one center coming to this, which can be shared by the world community.
And another point that we highlighted is how socioeconomic status really affects myeloma survival. that underserved communities are less likely to have longer times of diagnosis, like Dr. Kumar said. People of lower socioeconomic status are less likely to receive modern therapy with the 3-drug or 4-drug regimens, and less likely to receive stem cell transplant. As this meeting has mentioned, quite often, the stem cell transplant is so important for myeloma survival, and therefore the insurance and how much of funds that you have in your socioeconomic status really determines how long some people live with this disease. And the question is how can we remedy that?
Yeah, in the transplant, we feel like the data which are available is indicate that almost 20 to 30% patients are able to undergo transplant who are eligible, compared to nearly almost 50% or higher in the best centers in the Western world. So if one can bridge this gap to bring down to 40 to 50%, that really will help a lot. And secondly, in the transplant also, we can find some measures which can bring down the cost. For example, doing the non-cryopreserved stem cell transplant. So you don't have to freeze the stem cell, which will bring down the cost by nearly almost 10 to 15%. Similarly, like if you do the stem cell counting on day 4 of mobilization, then you can reduce the unnecessary harvest, like you can just limit to 1 and can bring the platelets up 4. So these are two of the points which at least can bring down the cost of transplant to many of these centers in the Asian countries.
And therefore making it more accessible to so many more people. The other thing, and before we talk about solutions, in fact, I'm going to dovetail into solutions right now, is clinical trials. That this meeting is just full of incredible results of clinical trials. One thing that we know is that for clinical trials that have gone to the FDA for drug approval, that on average about 4.5% of the patients involved in those clinical trials are people of any other ethnicity other than white, which is very difficult to apply the results of some of these clinical trials to patients who are non-white when the number involved has been so low. And the solution really is for people, for everyone, and especially people of color to be involved in clinical trials. The clinical trials in myeloma have never been safer. They've never been more competitive. The drugs that now are involved in clinical trials are safer, better, more efficacious than they've ever been and I've ever seen in my career. So this is an opportune time to be involved in clinical trials, especially people of color, so that we know that these drugs work for everyone. Because what we want to do is we want to cure myeloma, but you can't cure myeloma by curing a fraction of the number of people in the world. We need to cure myeloma for everyone. And for us to cure myeloma for everyone needs to be involved in clinical trials so we know these drugs work.
Another aspect could be like if we can do the screening for people, population, especially where they have the high risk population, or either because of age or because of some high risk factors like obesity or family history. Those people, if they're screened and found to have the uh, positive on the serum M protein or serum protein lactophoresis, then they could be investigated, and then you can really pick up them early and treat them early. This will definitely improve the results. So that was one aspect. Secondly, other suggestion was that if we can do the trials with the available drugs, a lot of generic drugs are available in many countries in Asia. So one can do a good trials with a large number of patients with 2 or 3 drugs, or now because the daratumumab is not available everywhere in Asia, only to very few people who can afford it. So even the doing trials for the 3 drugs, many of these countries, if we can have larger database, which can really help us to get the good data that how people do respond to these drugs. And secondly, also there may be people ethnically they have a tolerance may not be so good. Like especially I know in northeastern part of India, where the people have the difference in the tolerance of many of the drugs like bortezomib because of the genetic background is such. So some of this data has never been brought out, uh, which also can help actually to the world community to know that there are people, there's some ethnic group, like we have some data from Japan. Similar to that, in the northeastern part of India, they have this genetic propensity that they may have poor tolerance to some of these drugs. So that was another thing. Third thing which we thought for the relapsed and refractory, many of the new end drugs, like especially the antibodies, CAR T cells, and then the isozumab, these drugs are not easily available for most people actually. So even going back to cytotoxic with combination of novel agents, like we can use so-called metronomic therapy, which could be very, very useful for many of these patients, at least for some group of subgroup of people, which can give the equivalent results rather than jumping everything on the high-end treatment.
One thing that can be done to bring clinical trials to a broader population and to again increase the diversity of clinical trials, decentralized clinical trials. What does that mean? Well, right now, a lot of the clinical trials, a lot of the best clinical trials that are out there are centralized at major academic centers. And of those, there's only a few that have, the myeloma, the top myeloma trials. Why can't we bring those clinical trials to your backyard? I have patients that travel 2-3 hours to see me. I do telehealth to people, around the world. Why not bring those specialists and bring those clinical trials to your local clinic? And that's the idea of decentralizing clinical trials. Instead of doing it at the traditional places that have done clinical trials for decades, bring the clinical trials to your local clinic in the inner city, to your local clinic in rural communities, to your local clinic in the suburbs where people don't have to travel as far. Because to have myeloma, to have cancer, and to travel hours and hours for clinical trials is a huge barrier. And so if we can bring clinical trials, and those steps have already been taken. Already, a lot of clinical trials in the pharma companies are looking at doing clinical trials at more local places to bring those top trials directly to your doorstep.
In fact, this will be a very good idea if we can use the telemedicine for this purpose. So people living very far off who cannot come frequently, and you can really monitor, you can help, give them the help from your place and with the help of the local physician or hematologist or oncologist, and can do those kind of trials and can compare the results. The actual real world data can come from those trials rather than doing selectively in a very, very specialized centers.